Hi, my name's Liz Farrington. I'm a consultant nurse for hepatology from the Royal Cornwall Hospital, and I'm here today for the BLNA virtual conference to give a short presentation on autoimmune hepatitis. I have no declaration of interest, and so today I'm going to talk about how we diagnose autoimmune hepatitis, how we induce remission in patients, how we maintain that remission, and then what happens when things don't go according to plan. So what happens when patients relapse with their autoimmune hepatitis, or in fact they fail treatment completely. So autoimmune hepatitis, or AIH, is a disease that's found worldwide, and it's of unknown etiology, with most cases having no identifiable precipitant. We do, however, have a good understanding that there are potential triggers, and these triggers may include viral infections. For example, we've seen documented cases of autoimmune hepatitis after viruses such as hepatitis A, hepatitis E, cytomegalovirus, and Epstein-Barr virus. There are documented cases following on from exposures to certain drugs, and some of those drugs can include interferon, antibiotics such as nitrofurantoin, and minocycline. And there are research into other environmental factors and whether they play a role in the development of autoimmune disease. There's a thinking that individuals are genetically susceptible, and what's happening is that these triggers are promoting a T-cell mediated cascade, which is directed against the liver antigens. And what this leads on to is a progressive destruction of hepatic parenchyma, which can lead to cirrhosis, liver failure, and ultimately death. If we look at the occurrence AIH, the prevalence of AIH is 10 to 17 per 100,000 population in Europe, and it can account for up to around 23% of all chronic liver disease. It is a female predominant disease, with over 70% of patients being female. And in the UK, it tends to be more common in older than in younger patients. And in the UK, in the older patients, there is a male predominancy. With regards to liver transplantation, this is required in around 10 to 20% of patients with autoimmune hepatitis during their lifetime. So if we look at how patients present clinically, well, some can present, just under half can present with a severe hepatitis. And when we identify autoimmune hepatitis, 30% of patients will already have established cirrhosis. Some are found incidentally, having blood tests undertaken for routine monitoring of other diseases, and an incidental finding of abnormal liver function test will point to the diagnosis, and rarely patients will present in acute liver failure. The symptoms of AIH, as you would expect with a liver disease, fatigue is very common. 85% of patients reporting fatigue, right upper quadrant pain, joint pains, nausea and loss of appetite can be common. But in at least a quarter of patients, there will be no underlying symptoms at all. With regards to physical findings, well, with patients presenting with severe hepatitis and evidence of cirrhosis, you will have physical findings such as hepatomegaly, features of portal hypertension with splenomegaly and spider nevi. Some patients may present decompensated with ascites, encephalopathy, or jaundice. And those patients who are in acute liver failure should be referred directly to a transplant centre. It's worth noting that in up to half of patients with autoimmune hepatitis, there may be a concomitant other autoimmune disease going on. So patients may have other liver autoimmune diagnoses, such as primary biliary cholangitis or PSC. Inflammatory bowel disease is common, with ulcerative colitis being found in a quarter of patients with autoimmune liver disease. Celiac, rheumatoid arthritis, systemic lupus, thyroid problems, MS, and pernicious anemia. So it may be that one of these diseases has been diagnosed first, and then autoimmune hepatitis comes along on the backing of this. With diagnosing autoimmune hepatitis, no one test is any good on its own. So the diagnosis absolutely rests on a combination of compatible biochemical, immunological, and histological features. You will see predominantly within the liver enzymes elevation of the ALT and AST. If the alkaline phosphatase is significantly raised, so more than twofold, you may well be considering an alternative liver autoimmune condition such as primary biliary cholangitis, or in fact an overlap syndrome, of which I'll talk a little bit about later on in the slides. The majority of patients will have a raised immunoglobulin G, so you'll find that in at least 85% of patients. And when we're looking at other immunoglobulins, IgA and IgM, for example, IgA elevation is commonly found in steatohepatitis or drug-induced liver injury. And if you have a raised IgM, you would be considering primary biliary cholangitis. So we have autoantibodies, and autoantibodies are a group of antibodies that are immune proteins that mistakenly target and damage specific tissues or organs of the body. And with autoimmune hepatitis, these can be categorized into two subtypes. And in most patients with autoimmune hepatitis, you will find detectable autoantibodies. So if we look at the two subtypes, well, type 1 is the most common subtype in autoimmune hepatitis and found in around 75% of cases. And this you will find you will have a positive ANA or anti-nuclear antibody, or SMA positivity, which is your anti-smooth muscle antibody. In type 2, which is less common, anti-liver kidney microsomal 1 antibodies are positive. And this is a type of autoimmune disease that you will normally find in children, young adults, has a very severe course and will need long-term maintenance and can be quite difficult to treat and manage. It is worth noting, however, as well, that in up to 25% of patients possibly who have autoimmune hepatitis, there will be undetectable titers of the conventional autoantibodies. And some of these patients will be labelled across time as having a cryptogenic chronic hepatitis. Liver histology is really important. So we have FibroScan now, so we use histological diagnosis a lot less, but it is really, really important for autoimmune liver disease because biochemical and immunological blood tests are not enough on their own for a definitive diagnosis. And to give an example of that, so 20% of patients who have biopsy proven non-alcohol related fatty liver disease did actually meet diagnostic blood testing terms for autoimmune hepatitis pre-biopsy. So they went into the biopsy thinking that the diagnosis was going to be autoimmune hepatitis, but in fact it turned out to be steatohepatitis. Liver biopsy is also important for prognosis. So those who present with cirrhosis or very advanced fibrosis are likely to have a poorer prognosis than those without. And it's also really important to follow up with regards to resolution of disease, although there's not really a consensus as to when. And liver biopsy should be performed in all cases unless there are active contraindications to biopsy, which are if the patient absolutely doesn't want it, very abnormal coagulopathy, or tense ascites. And so the histological features that you will find on biopsy, and I've put some slides there to show you with all these black dots, is this rich plasma cell infiltrate, or this interface hepatitis, which is seen in most samples of autoimmune hepatitis. There will be ballooning degeneration of the hepatocytes in many cases with zonal necrosis, and it's the exclusion of other features as well that allows the diagnosis of autoimmune hepatitis. And the next slide I'm going to show you is more for reference. I won't talk through it, but it's the International Autoimmune Hepatitis Group diagnostic criteria. And this can be found easily on the internet and is a useful reference point when you're managing patients and diagnosing autoimmune hepatitis. So if we come to look at treatment, well, most of the major advances for autoimmune hepatitis were made in the 70s and 80s, so a long time ago, based on controlled trials in England and the United States of America. And so the whole aims of treatment are to induce remission, so dampen down the autoimmune activity that is attacking the liver function. We want to prevent disease progression. So if there's scarring there, we want to stop that getting worse. And if anything, we want to revert that scarring that's there. We want to minimize relapse of disease, which can be very common with withdrawal of treatment in autoimmune hepatitis. Overall improve survival, and absolutely minimize the toxic side effects of medication. So this is a balance between treating the disease, toxicity of the medication. So who are we going to treat? Well, patients that are symptomatic, young patients in the hope of stopping progression of scarring over decades. We will treat patients that have ALT abnormalities and raised IgG, who have signs of interface hepatitis activity on biopsy with necrosis, and also patients with cirrhosis who continue to have mild histological activity. So that activity has not been completely burnt out by the scarring over time. Lots of centres do lots of different things in terms of treatment. So as a sort of suggested point, and probably what is the most common routes of induction strategies, is that we start steroids. And those steroids are in the form of prednisolone. And depending on disease severity at time of presentation, you can start the steroid off anywhere between 15 and 60 milligrams. I have always been a bit uncomfortable with very high doses of prednisolone, such as 60 milligrams. So I tend to start off between 30 and 40 milligrams as a standard. And then the aim with the prednisolone is you go in with a higher dose, which dampens down the disease activity very quickly. And then you can titrate that down as you're having remission and your liver function tests are normalizing. We introduce a second-line immunosuppression. So the most common immunosuppression to be used is azathioprine at an approximate dose of 1 milligram a kilogram per day. And personally, what I do is I start this a month after I've started the prednisolone. And that is just so if patients are going to have side effects from medication, you have a little bit of an idea about what's causing the side effects. So I would start with prednisolone, go for a month, and then introduce the azathioprine as the prednisolone is being tapered down. Regular blood tests are really important because of the side effects of immunosuppression, and bone care is also really important. So patients should have an index bone density scan and supplementation with calcium, vitamin D and bisphosphonates as required. Now, for some patients, prednisolone is a big no-no, potentially due to some of the side effects, psychosis, or if they have difficult to control diabetes. And if there is an absence of cirrhosis, then budesonide can be utilised rather than prednisolone, and it tends to have a lesser side effect profile. So steroids, as we know, can cause obesity, cosmetic changes, facial hair, induce diabetes, cause ulceration, as well as psychosis, high blood pressure, cataracts. We know these are toxic drugs. And also with azathioprine, around a quarter of patients will develop a side effect of azathioprine, and a lot of that tends to be around abdominal side effects, nausea, vomiting, diarrhea, and 10% of patients will need to come off the drug. And you can consider an alternative immunosuppression. And I've just listed some of the side effects to azathioprine below. We also need to be concerned about extrahepatic malignancy with long-term use of drugs such as azathioprine. And azathioprine itself has a probability of tumour recurrence is 3% after 10 years and a relative risk of 1 in 4. So this has implications particularly for our younger patients who are likely to have decades of therapy. And here's where we need to be potentially considering treatment breaks across time. Patients on immunosuppressive therapy should have regular monitoring. Initially, we will do weekly liver tests. We will look at blood sugars and full blood count. And we do that for 4 weeks and then move to monthly or 3 monthly intervals, depending on the response and depending on the blood set profile of the patient. And as I've said before, calcium, vitamin D, bone protection is really important in this patient group. I think that, you know, when I am diagnosing somebody with autoimmune hepatitis, there's a good reason to be positive, because most patients will respond to therapy. So in most patients with either moderate or severe autoimmune hepatitis, you will see the liver enzymes responding very quickly. You will see the ALT falling quickly. And remember, the whole aim is about getting biochemical and histological remission. And 65% of patients will have this achieved at 18 months, and 80% of patients will have this achieved at 36 months. And remission, again, depending on dosages of medication used, side effect profiles, will normally take around 18 to 24 months of treatment. If, however, and if they're even mild, you have continuing abnormalities in liver function tests, a persisting hepatitis, that is going to lead to a higher chance of patients having a relapse if you withdraw treatment, and overall a poorer outcome and a quicker progression to cirrhosis. So if we look at the long-term treatment pathway, so we look to normalise the liver enzymes, particularly the ALT and the IgG, and when we have that for a period of 12 months, that's when I like to do a follow-up liver biopsy. If that liver biopsy shows no disease activity, so no evidence of interface hepatitis, then I would withdraw steroid treatment at that point. If the interface hepatitis was continuing, I would continue with dual immunosuppressive therapy, so azathioprine plus a small dose of prednisolone, and monitoring numbers very closely. And then you'd continue with the azathioprine for a minimum of 6 months with the prednisolone, prior again to trying to withdraw the prednisolone in those patients that have likely relapsed. But in terms of long-term azathioprine treatment, I will tell my patients that they need to probably be on therapy for a good 4 years before I would consider withdrawal. But again, there's diversity amongst treatment centres as to the pathway. So around 5 to 10% of patients, the liver tests just do not improve. And these tend to be in patients who are younger, those who have had a severe acute presentation with jaundice, high MELD scores, little change over 7 days when you've introduced the steroid therapy. And for these patients, you need to be thinking about and starting to have those discussions with a specialist centre or a transplant centre. For patients that are slow or not responding, there are some other alternatives to try. In the absence of liver failure, the prednisolone could be increased, the azathioprine could be increased. It's always important to consider whether your patients are adhering to their medications properly, or if there are potentially malabsorption issues, if there's concomitant celiac disease. And in these cases, again, 70% of patients will have a biochemical improvement over 2 years, but only 20% will go into histological remission. So you may well want to start considering an alternative immunosuppression. And some of those alternative immunosuppressions may be the use of mycophenolate, cyclosporin, tacrolimus, or bringing the patients in to do an intravenous pulse of methylprednisolone. There's a choice as to long-term maintenance. So the treatment across all liver diseases, I think, needs to be individualized, but particularly in the case of autoimmune liver disease. So you may wish to consider withdrawing therapy if you've seen a really good biochemical and histological response. You would be happier about withdrawing medication if the patient has not presented with cirrhosis or decompensation of liver disease. You really would want to consider treatment breaks with patients that have a history of malignancy, and also the age factor, which I discussed briefly earlier. And those patients who are diagnosed at a young age, who are looking at decades of therapy, there are definitely, I think, a call for some treatment breaks along that time as well. And then we have those who relapse. So when we withdraw autoimmune hepatitis treatment, a large proportion of patients may well relapse. So it can occur in up to 80% of patients. And you will see that on your blood testing with your ALT and your IgG going back up again. And relapses have a frequency, an increased frequency of the development of cirrhosis, the development of varices, and overall mortality. So prognosis overall, well, if you present with severe disease, so your ALT is times 10 the upper limit of normal with a very raised IgG, if left untreated, there would be a 6-month mortality of 40%. Those who present with bridging or multifocal necrosis histologically, 82% will develop cirrhosis at 5 years with a 45% mortality, and mild disease, 49% will develop cirrhosis with a 10% mortality at 15 years. So overall, when we diagnose the patients, if we get them onto treatment early, the prognosis is good. I just wanted to mention very quickly a couple of special populations. So overlap syndrome is quite common with autoimmune hepatitis and primary biliary cholangitis. And PBC is an autoimmune cholestatic disease where you will have destruction of the interlobular and septal bile ducts. These patients will have an AMA and M2 antibody positivity and quite often present with significant pruritus. Fatigue and joint pains are also common. So with autoimmune hepatitis, when you're looking at a liver biopsy, 10% of those patients will have features that could be consistent with PBC. And with PBC, 20% have features that are consistent with autoimmune hepatitis. So if you have both, so you have interface hepatitis, which is the autoimmune hepatitis part, or the destruction of bile ducts, which is the PBC part, overlap patients will have a poorer prognosis. I wanted to mention pregnancy as well because it's a topic that often people ask about. Azathioprine is normally continued in pregnancy, prednisolone if required. Patients with autoimmune hepatitis who have established cirrhosis and become pregnant are at quite a significant risk of decompensating liver disease. And those with autoimmune hepatitis have a slightly higher than normal frequency of premature delivery, lower birth weights, and fetal loss. So there is a small risk to the fetus, but actually there's more of a risk to the mother. There's a risk of a flare in the autoimmune hepatitis. And patients who are of childbearing age, who have very advanced cirrhosis and autoimmune liver disease, are actually in most places advised against pregnancy. So if I just conclude, I think autoimmune hepatitis has a good prognosis in general. Patients are in general responsive to immunosuppression. Aspiration overall should be the lowest achievable histological and biochemical activity with a minimum of side effects. So this is where I'm talking about disease treatment versus treatment toxicity. So it's about finding what you can get away with at the lowest levels in order to put your patient into remission. Relapsing is frequent of immunosuppression, up to 80% of patients, but sustained remission of treatment is possible. Transplantation is occasionally required, but we certainly need some more research for newer immunosuppressive therapies. So if you remember at the start, we are still basing a lot of our autoimmune hepatitis treatment on those trials in the 70s and the 80s that weren't randomized controlled trials. And I'm currently on the BSG working group for the development of further autoimmune hepatitis guidelines. So I think as a liver community, we're all aware that there is a lot more that we can learn. So I'm very thankful for you listening to my talk this afternoon. Thank you very much.